Inviting me as a speaker to this prestigious conference. The preceding talks have formed a firm background for the topic that I'll be deliberating here today. And the preceding talks have precisely talked in detail about the challenges of sensitization. In the last talk, we have had extensive discussion on the role of xenotransplantation. So we basically understand that immunological barrier is the biggest challenge against the successful transplantation. Nearly 30% of patients in India and abroad have some sort of pre-transplant donor-specific antibody that precludes them from having a good transplantation or proceeding with the transplantation, because sensitization not only increases the waiting time in case of these patients, it also results in significant graft loss. So we have several tools for removing these antibodies, which we will see. But we are very familiar that pregnancy, previous transplantation, or multiple blood transfusions, all this can give rise to sensitization. And it's not that we haven't fought against this sensitization. We have devised, we have had discussions on how desensitization protocol can be planned, but there are certain difficulties with all these desensitization protocols, and we also have different tools to measure this sensitization. In India, we have had tools. In India and most parts of the world, we have PRA, which is a percentage of local pool of organ donors to which a patient has reactive antibodies. If a patient has got 80% PRA, it would be considered cross-matched and incompatible with 80% of donors. Whereas in UK, they use something called calculated reaction frequency, which is an estimate of the probability of an allocated deceased donor being antibody incompatible by comparing that patient's recipient's antibody profile with HLA of 10,000 deceased donors. So, despite having certain technologies, certain protocols to overcome this sensitization, we have significant AMRA risk. But don't forget, despite all these limitations, if we can have transplantation after desensitization in these highly sensitized patients, their survival is going to be still better if they had been on dialysis. So transplantation definitely gives a survival advantage. So our efforts should be to give a benefit of transplantation to these patients. We have several desensitization techniques that most of you are familiar with, such as plasmapheresis, immunoadsorption, IVIG, PP, with low-dose IVIG or high-dose IVIG and anti-CD22 antibody, that is rituximab. Despite having all this, there is an unmet need for these sensitized patients where the role of Imlifidase is. So now what is Imlifidase exactly? Imlifidase is a novel solution. It is a recombinant cysteine protease derived from Streptococcus pyogenes that specifically targets and degrades human immunoglobulin G antibodies. Those of you who are not familiar with this drug and those of you who are familiar with this, let's go through this wonderful molecule which has got significant promises for us. It cleaves immunoglobulin G into Fc fragment and Fab fragments, effectively inactivating the immunoglobulin G dependent effector functions which are responsible for resection. In fact, the harmful effects of the immunoglobulin G in resection are precisely or basically mediated by the Fc portion of the antibody, including the regulation of immune cells and complement and cell-dependent cytotoxicity. And this, in fact, results in graft loss. So when we look at the molecular background and mechanism, as I have stated, it's an immunomodulatory agent derived from Streptococcus, and it's a cysteine protease that basically cleaves immunoglobulin G in a two-step process. The first step occurs within minutes, where it divides the immunoglobulin by cleaving one chain into single cleaved IgG. And in the second step, which occurs within hours, it completely cleaves the IgG into Fab2 and homodimeric Fc fragment. However, it doesn't inhibit or doesn't destroy or doesn't cleave other immunoglobulins. Not only that, it also leaves other human proteins intact, but it cleaves all four subclasses of immunoglobulin G. Now, when we inactivate the IgG-dependent Fc effector functions, what do we essentially achieve? We inhibit important, all that is wrong with it, all that is responsible for a graft loss, such as antibody-dependent cell-mediated cytotoxicity, antibody-dependent cellular phagocytosis, or complement-dependent cytotoxicity. All these are, we can halt this potentially these are the things that affect a graft which is so precious for us. And not only that, it also cleaves B cell antigen receptors on immunoglobulin G positive memory B cells, disrupting the antigen recognition and preventing differentiation into antibody producing plasma cells. However, the Fab to portion activities such as intracellular signal binding and receptor domain binding, which are essential for virus inhibiting properties, are not inhibited, which may be a desirable thing as well. When we look at the pharmacokinetics and half-life of this drug has a half-life which 4.9 hours, and after 4.9 hours, this is followed by a rapid clearance, which allows for a transient effect of immunoglobulin G levels, minimizing the potential side effects, which is both a good and bad thing. And the lower levels of intact immunoglobulin G are in fact achieved between 6 to 24 hours after the administration of the drug, indicating the effectiveness of the enzyme in reducing the immunoglobulin G. Now, before we think of this magical drug turning into reality, we need certain clinical experience, and that comes from trials. There have been several trials, but I'll just focus on a few of the important ones. Jordan et al. Actually took this trial on 2 single-arm open-label phase 1-2 studies. In this study, there were 25 patients, 14 were from US and 11 from Sweden. And 22 had positive cross-match, 18 with flow cytometry cross-match, 18 had flow cross-match positive, and 2 patients had CDC cross-match positive. What they found was that Imlifidase was given 4 to 6 hours before the transplantation in a 15-minute injection, IV injection infusion over 15 minutes. The Swedish cohort, it was followed by anti-thymocyte globulin, the equine anti-thymocyte globulin, and in the US cohort they had given alemtuzumab. And additional treatment in the US cohort, they give IVIG, that was 7 to 14 days after transplant, and rituximab 14 to 21 days after transplant. What they found out is that 24 out of this 25 patients had a functioning allograft, and the graft rejection, which occurs in 7 in US and 3 in Swedish cohort in a time frame of 2 to 5, but the graft rejection, though, eventually they overcame. Only 2 patients, only 1 patient was lost, which was of course due to non-HLA IgM and IgA antibodies. Now, most patients had good response to treatment despite occurrence of AMR in some cases, and the mean GFR was also equally good at 1 to 6 months after transplant. That was quite desirable at 58 milliliter per minute. In second study, which was conducted by Heidis et al., there were 19 patients, which was a multicentric and a multinational study as well. And the condition was, of course, the essential thing. These patients had to have incompatible living or deceased donors. So both living and deceased donor were taken into account. 13 patients received kidney from deceased donor and 5 from live donors. These patients had essentially greater than 3000 MFI of pre-transplant donor specific antibodies, and the CPRA was more than 99% in these patients. And they again received a start dose of Imlifidase 0.25 milligram per kg. Some patients who did not achieve cross-match negativity were given 0.25 per milligram per kg. A second dose was also given, and these patients received either equine ATG or alemtuzumab, and some patients, and these patients were given on day 7 IVIG, and on day 9 they were given rituximab. And when we look at the outcomes of this trial, 18 patients of 19 patients, 18 out of these 19 patients underwent transplantation, and the success rate of patient survival was 100% in 6 months, and the graft survival was 17 out of 19 patients, that is 89% at 6 months. And the primary endpoint of the study was achieving a cross-match negativity, which they achieved in 16 out of these 18 patients, that was nearly 89.5%. And the antibody mediated rejection was around 40%. So the third study we'll be talking about is a pooled analysis of 4 open-label single-arm phase 2 clinical trials, and it was based on 39 patients. The incidence of AMR was 38 patients. These patients was found out that those patients who had MFI pre-transplant in very high levels had a higher incidence of AMR as compared to the other patients. Their graft survival and patient survival was, of course, the patient survival was 90% at 3 years, and 84%. Graft survival was 84%, mean GFR was 55, and so having had this, some of these important studies, how can we put Imlifidase into clinical use? We understand that Imlifidase use is followed by a rebound of these immunoglobulin G antibodies, and the high chance of AMR continues to remain as with most desensitization protocols. Therefore, we need to have an effective protocol, and Kausi et al. Have designed a protocol where they have started with giving, apart from imlifidase, of course, they give corticosteroids. It's quite similar to the way we normally use. Start with a high dose of corticosteroids. They have given 500 milligram on day 0, then day 1 to 3 they give 250, then on day 4 125 milligram, and day 5 20 milligram, then after 5 milligram per day, and they have given ATG or alemtuzumab. This protocol suggests giving a rabbit ATG after day 4 of giving imlifidase, and merely because of its more efficacy as compared to alemtuzumab or equine ATG. IVIG and rituximab are given at day 4 and day 7 respectively, and after that it is followed by the conventional 3-drug regimen that we normally are familiar with. And they suggested DSA levels should be measured at 2, 5, 7, 10, and 15. The protocol biopsy at 1, 3, and 12 months to detect the, at 1, 3, and 12 months to have DSA subsequently, and protocol biopsy on day 7 to 10, and subsequently on months 3 and 12. So, having had this discussion, let me emphasize a few of the important points about imlifidase. How important it is to have a drug which can have a high specificity against immunoglobulin G. It gives near total elimination of immunoglobulin G within 2 to 6 hours, but it's not without its shortcomings, which we'll look at subsequent slides. The European and French have designed their own guidelines how to use imlifidase, but there are considerable challenges remain. The important challenge here is to have essential diagnostic tools at our disposal, because it's not an everyday thing to have CDC, flow cytometry, or multiplex antigen-based assays at most of the centers where we are going to have transplantation. It's not just availability or accessibility of these tests, it's also an appropriate or correct interpretation of these tests, which is a major challenge, because that can distinguish between having a transplant and not having a transplant. So I'll just focus once more on these challenges before I conclude my slides. And one of the challenges of imlifidase is that it cleaves immunoglobulin G antibodies, but it also poses a challenge against having antibody-based other agents. Such, for example, rabbit ATG, it also cleaves the rabbit ATG. So we need to have 1 week gap between rabbit ATG and imlifidase. It doesn't disturb with equine ATG or alemtuzumab, and drugs like adalimumab, basiliximab, and denosumab, all those drugs that are necessary, they can be given after a gap of 4 days, and IVIG has to be given at a gap of 12 hours. And don't forget infusion-related allergic reactions, which can be managed with intense observation during administration of the drug, and there is temporary reduction in toxin production, there is infection challenges, which of course individual centers have their own infection-based prophylactic regimens which have to be looked into, and which will have to look into the different contraindications in course of time. So, as I come to concluding of my presentation, we'll all have this question in our mind: can imlifidase be the game changer that has long been awaited? Yes, it's an exciting agent, but it is also promising as an alternative to pre-transplant plasmapheresis, which could provide a major benefit both to patients in terms of time saved. It can also have promise for other organ transplants, because as far as heart and lung transplant concerned, we do not have an option of having live donors. So probably, or perhaps our experience with kidney transplantation might lead us the way to have imlifidase in wider solid organ transplantation. Maybe imlifidase one day have a role in xenotransplantation with eliminating non-immunodependent epitopes, and maybe we will be able to re-engineer imlifidase to make it less immunostimulatory. So of course we need more studies to establish this breakthrough drug as a reality. Whether it remains in the realm of magic or returns into everyday reality, only time will tell. For that, of course, we need more studies, more work, and a lot of promise.